Hello everyone. Today I'm going to talk about urine examination. I have already told you about the HbS, hemoglobin estimation, right? So I'll be taking 2 classes about urine examination. So the overview of the class will be about what is urine, why we should do urine examination, the sample collection, storage, the physical examination, the chemical examination. I will be covering only half of the chemical examination today, and the rest will be covered tomorrow, right? With urine microscopy in the next class. So urine is the, whatever we take in either milk, alcohol, whatever you take, there is some amount of water in it, and that is being excreted in the form of urine, right? So kidneys are these specialized organs which are doing that. So the urine is defined as a fluid excrete of the body formed in the globule, concentrated by the multiple exchange system. That means, see, again in the urine, in the kidney, you have the reabsorption taking place of the sodium, water, 75% of the proximal convoluted tubule, and then the bicarbonate and the the hydrogen, everything is kept like that. Means the acid-base balance is kept by the kidney because of this, right? So that is the importance of the urine, that whether it is more or whether it is less, whether it is concentrated, not concentrated. So that will give an indication of the disease. So we have to do urine examination because you need to screen certain diseases, then monitor certain renal diseases, and other, it is an indication of other systemic disease. For example, you find sugar in the urine, then it is called as glycosuria, right? Then you have to check for the plasma glucose, then compare both. If the plasma glucose is not raised, then you must think of renal glycosuria. The progression and response to therapy, urinary tract infections, there can be burning micturition that can be happening, right? There will be an urge to micturate, and then itching will be there, burning will be there, all these symptoms of urinary tract infection. The color will be concentrated, so there will be variation of the normal urine output, so that we can think of some systemic disease or a renal disease or the disease pertaining to anything in the flow tract, right? ARF, CRF, malignancy, acute glomerulonephritis, acute interstitial nephritis, and hematuria. So how do we collect the sample of the urine? Usually the morning sample is the best sample because there is a gap. After that only you are micturating, that's one thing. So that will have all the preserved casts and crystals, all the formed elements are preserved, and that's the reason why this is the most representative sample, the morning sample. What do you mean by the random sample? Random sample means at any time of the day you just go and give the urine for routine examination. That is the random sample. Timed sample means, for example, you want to check some pharmacological drug, if it is getting excreted in the urine or not, then you will time the sample after you take the drug, after 12 hours, after 24 hours. You are telling the patient to come back and give the urine. So that is a timed sample. Others are the postprandial sample that is usually taken. See, for example, they are testing for sugar routinely. What they do is they take fasting plasma sugars will be tested. Then what you also test is the fasting urine sample. That is the early morning sample. And then after having the breakfast, after after 1.5 hours, within 2 hours, what they do is they check again the postprandial blood value, right? With that, you correlate the urine sample value also. That is usually done for the postprandial. That means you take food and then after 1.5 hours, within 2 hours, you check the sample whether there is urine sugar or not. If so, how much it is there, then it is called as postprandial. Catheterized sample collection is done for those who are bedridden, but you should not do it for already ambulatory patient, because you may introduce infection via the catheter to the person who is ambulatory, right? Clean catch. Clean catch specimen is usually taken for the bacteriological examination. That means It has to be cleaned. Usually, we'll take the midstream urine. Why midstream urine? Because the bacteria or the contaminants of the urethra which are there, you are trying to discard them and then you are collecting the midstream sample. But then if you are if you want to check the clean catch, you do not want any other organism to be present, which are usually normal common cells, then what do? You kind of, for males, you take a soap water and then clean the glands penis, then you collect the uh, urine after thorough washing. Then the females, it's same thing. You will try to clean it up with soapy balls, and then you are trying to diverge the labia and then collect the clean urine so that there are no contaminants. This is for the bacteriological examination because we do not want any other organism to interfere when we are doing a culture or AFB or something like that, when we are suspecting a urinary tract infection, possibly bacteria. So what are the special techniques for urine collection? The suprapubic aspiration in case of infants in anaerobic infections, urethral catheterization in infants and comatose patients, ureteral catheterization through cystoscope for culture. So basically, I was asked this question in my Viva PG examination. I still remember that. They asked me whether how to collect infant urine. So because the textbooks say that it is suprapubic aspiration, if we say that answer routinely, I mean, I don't think no parent will agree to do a suprapubic aspiration by putting needle in a little one, right? So what you do is usually you prefer to put a bag and then you collect the urine, okay? Otherwise, in the worst circumstances, when it is getting contaminated or there is another reason for you not able to collect the urine via the bag in the infant, then you prefer doing an incision. But usually the suprapubic aspiration is not routinely done, okay? Urethral and ureteral catheterization can be done. Okay, these are the special techniques. That's why we're not saying they are routine techniques. They are special techniques. So until now, what I told you is what is urine and what are the indications, various malignancy, infections and renal causes, pre-renal causes, post-renal causes we have discussed. Then I've also told you about what kind of sample we have. Sampling technique is there, like morning sample, random sample, all of that. And then we've talked about the special techniques, right? So the next one. So some villages there which it's not having any urine analyzer or something. So you have to have that urine collected in a very clean bottle, which is dry, sterile bottle, and then that is tightly capped and it is labeled properly. Then it will be sent to some city lab. Okay. So in the meantime, there can be some changes that can be happening in the urine, right? So because it is containing some organism, maybe it can contain some elements, it can contain the cells, right? So that's the reason why there is a time limit for the preservation. If you want to have the time to be extended to test, then you have to add some preservatives. So what is preservation? Usually, urine is preserved at 4 to 6 degrees. That means just a refrigerator. You should not freeze it, but put it in the normal refrigerator. That can be there preserving the urine for 1 day. Okay. Then sometimes if you want it to be used for multiple purposes, then you can keep it for uh, in a frozen state in aliquots. Aliquots means there will be small test tubes. These are called as aliquoting. Like in that, you will kind of take the exact amount of urine needed for the test and then you put that. Okay. And then you take 4 or 5 bottles, freeze it, name it, label it, and keep it in the freezer. So that is the second thing. There are some preservatives I told you. These preservatives usually, see, what type of preservative you want to use depends upon what kind of examination you want to do. For example, see, once I add some kind of preservative, okay, then what happens is that, see, we are using preservatives to store the urine for examination so that the physical and chemical properties of urine are not disturbed, right? But there are some preservatives, for every drug it has a side effect, right? So in the same way, if you add a preservative, then the preservative will kind of affect some physical and chemical properties. So depending upon that, you should choose your preservative. Okay, so the preservatives are, we'll start with one, sodium fluoride. You have to just remember, in the practicals there is no way out, but then you have to remember the grams and how many liters, all of that. So 0.5 grams to a 3 to 4 liter container for 24-hour urine sample. So 24-hour urine sample is morning 8 o'clock to next day 8. You know, that 24-hour sample you take, that is the urine sample. Useful for glucose estimation, but this inhibits the glucose strip test. So that means initially you take the urine, then you are not trying to put the reagent strip test, but you want to kind of use the glucose, test the urine sugar after some time. Okay, you are not sure of, you are not having the reagent strips or whatever. Maybe you want to check it very red. So that's the reason why you may have this interference of the reagent strip test. The second one, toluene. It is an all-round preservative at such form that it forms a thin layer over the urine. Okay, it is a very good preservative, toluene. Then boric acid, concentration of 5 grams per 4 ounces of urine. This is used for hormonal assay. See, that's the reason that you should keep in mind what test to do, so that you will add that necessary preservative which preserves that hormones. For example, boric acid is good for preservation of hormones. If you add sodium fluoride, it is taking care of only glucose in the urine, not any other thing. So depending upon what test you want to do, you have to add that preservative. Concentrated HCl, 10 ml for 24 urine sample. This is for chemical analysis. Okay. So then chloroform and formalin, 1 drop of formaldehyde for 30 ml urine. So again, this interferes with sugar. Usually, if you are doing a urine microscopic examination about, you want to see cells, you want to see whether there are some cancer crystals, then you use chloroform or formalin. If you want to do a test of sugar, you are not choosing chloroform or formalin. You are choosing sodium fluoride, right? So thymone, this also interferes with the sugar and ketone bodies. Sodium carbonate, half teaspoon added, and then camphor. If you have nothing, you are in a village, then it is camphor. So preservative depends upon the type of the test you want to do. We've seen a lot, that is a camphor, thymol, toluene, boric acid, concentrated HCl, sodium fluoride. All of this can be used as urine preservatives. So as prerequisite, I told you the labeling and the test required has to be there. Then coming to the physical examination of the urine. So this is the container, this kind of a container will be given to the patient. The patient will be asked to discard the initial urine, then put the container to catch the midstream sample. Okay. For physical properties, you just remember physical properties of urine means it's like, you know, for a tea powder ad, you say Rangu Ruchi Chikkadanam, right? So in the same way, you can't taste it though, but I've just kept it for fun. So it is color. Obviously, you will see the appearance. That means, then taste. Remember odor. Okay, for urine. Then odor. Strength. Strength means pH, specific gravity. All of this. So remember that. So physical properties of any substance, you will be writing in these terms. So appearance, it is hazy or cloudy due to appearance of amorphous phosphates. So usually the appearance is pale yellow in color, and that is because of the urochrome pigment. That yellow color is imbibed in the urine. Okay. and other constant is water, right? So usually the appearance, if it is hazy or cloudy and not clear, then you should think of all these things. That is amorphous phosphates, amorphous urates, pus, bacteria, or chyle. So chyle, you will find it, it's mostly white. Then in bacteria, how do you kind of know that it is bacteria? You centrifuge it. That means centrifuge is nothing but you put it in a chamber, you do this. Like, you know, there is a centrifuge machine for that. You need not do it with your hand. So 3000 revolutions per 30 minutes, 15 to 20 minutes will do good enough. There will be a sediment that is formed. You discard the top layer of the test tube, what you have kept, and then you take that sediment and then see the thing. Okay. So how do you know that the appearance has been contaminated or is being hazy by the presence of bacteria? Is that you centrifuge, take a sample in a test tube, centrifuge it, 3000 revolutions. Revolutions is this, okay, number of times it swings. Okay, so revolutions for 15 minutes to 20 minutes, then you see a proper sediment, you discard, and then you see. And pus, just filter it, then you know that it is pus. Then amorphous urates, you heat it, you know it is urates. Then you add a little bit of acidic acid, then suddenly the turbidity or cloudiness or haziness is being lost, and then the urine becomes clear, then it is amorphous phosphates. Okay, so the first one, appearance. Appearance can usually is clear, pale yellow in color, so that can be modified as haziness or cloudiness by amorphous phosphates, urates, bacteria, or pus. That you do different tests and then you do, right? So coming to the other one, that is the color. I told you the urochrome pigment that is there, and small amount of urobilin and uroerythrin. Okay. The excretion of the urochrome pigment is proportional to the metabolic rate. That means, see, if the person is having, as you know, while I was talking about endocrines, I told you that the thyroid is the one which is central organ which pumps the metabolism, right? So whenever there is increased metabolism, as in hyperthyroidism, or the patient is having fever, then what happens is that the excretion of this urochrome pigment is high. So that's the reason why it will become more colored or appears more concentrated. Okay, that means more yellow. Thus, color indicates a degree of hydration and urine concentration. That means, see, if you are drinking more water, then you know it's clear. This yellowish to amber colored urine is a normal one. If it is red or pink, that means there can be stones, there can be hematuria, hemoglobinuria, or anything that is interfering and causing the red blood cells to ooze out either by friction of a stone or by some renal problem or a post-renal problem. Okay, then orange. Sometimes it can be there with dehydration and some issues with your bile duct. Blue-green, very, very rare, significantly rare, but if it is present, usually it may indicate bacterial infection. Dark brown, usually a dehydration or a liver disease or a porphyria. Okay, cloudy, either dehydration or there are proteins in the urine. Okay, the proteins in the urine can be seen in mild proteinuria in case of urinary tract infection, or a chronic disease of the kidney, that is any glomerulonephritis, that is nephritic syndrome, less than 3.5 grams per day protein, more than 150 milligrams per day. Then here you are seeing the cloudy urine with foam, which can be serious. So these are the colors, range of colors that can you see. Okay, so this is the picture of hematuria here, and then this is a picture of chyluria. Okay, just to denote, this is hematuria, this is a chyluria. So abnormal changes: bright red hematuria, reddish brown. I already told you porphyria is greenish yellow. Bile duct, I told you jaundice. Black albuminuria, milky white chyluria, that is lymph. Some drugs and food substances may alter the color of urine. So the first physical characteristic you look for, appearance. The second one is color, right? So third one, quantity. Usually it should be either 1 to 2 liters per day. 1 to 2 liters per day, that is 1.2, that is 1200 to 2000 ml per day. It varies more in the daytime than the night. If it is more in the night, you must think of any tubular injury, that is acute interstitial nephritis kind of thing, or you must think of diabetes routinely. Males more than females, urine excretion. Less than 500 ml is oliguria. More than 2000 ml is polyuria. Anuria is complete stoppage of the urination or less than 50 ml. So, order. See, I told you about these things by discussing about the kidney chapter. So, less than 500 ml oliguria can be present in acute renal failure. More than 2000 ml polyuria, acute interstitial nephritis leading to some tubular injury, and also diabetes induced renal damage that can cause polyuria, right? So anuria, that is like, that is renal failure, very high grade, that is in almost like end stage renal disease. You find this kind of a picture where there is very less GFR and then very less urine output. Okay. So we've seen appearance, color and quantity. Now order. A slight aromatic odor is found normally due to the presence of organic amino acids. So light odor will be there of urine. Okay, that is because of the organic acids. If it is having an ammonical odor, that means that is of a long-standing urine. This is because the urease which is present is converted to, the urea is converted to NH3 by the presence of the bacteria which are present normally in the urine. Okay, that is called ammonia formation, ammonical odor. Foul odor is seen in UTI, fruity odor, ketoacidosis, usually in diabetes or starvation you find this. Mousy odor, phenyl ketonuria. So remember appearance, color, quantity, odor. Then pH reaction, strength, remember that pH and specific gravity. So urine is usually acidic, slightly acidic. It may vary from 4.6 to 8. It is measured by pH paper, litmus paper, and nitrogen paper. Usually in labs we use litmus paper. Paper changes from the blue to red in acidic urine and red to blue in alkaline urine. That no change means neutral urine. Alkaline tide, after heavy lunch or exercise, the urine gives an alkaline reaction. That is called the alkaline tide. Remember that. So this is it. This is the litmus paper where you are seeing this red litmus turn blue. That is indicative of an alkaline pH. The blue litmus turn red. That is indicative of an acidic pH. So we also have a reagent strip test wherein you can have these values. Okay, then you kind of compare the color what you got with the standard on the bottle which is given. Then you can say that the urine is having this much pH. So acidic urine is seen in ketosis, diabetes, starvation and fever, systemic acidosis, E. coli and some acidification therapy. Alkaline urine, strict alkalosis, strict vegetarian, urinary tract infection with protease, alkalization therapy. So the examiner may ask you what kind of pH you find. If pH is 3, then it is acidic urine, right? So what are the conditions where you see pH 3 or acidic urine? They may ask you like that. Okay. So coming to this, it is a measure of the amount of solids present in the solution, the urine. So usually this is Squibb's urinometer. It is suspended, taking the urine here. So the measure of the solutes present in the solvent, that is the urine, is measured. The lower meniscus gives the value. Okay. The normal is 1.005 to 1.025. Some disease states may vary from 0.001 to 1.060. Usually the standard is taken, the standard of the specific gravity of water is 1. So usually we compare this urine specific gravity with that of the water. The highest specific gravity occurs in the oliguria. That is obvious, right? So if what do you mean by specific gravity is that if, for example, you are taking glucose. I'm just giving you an example. You take water and then you add glucose. Glucose is the solute. The water is the solvent, right? So the amount of the solute present in this solvent, that is the water, is having a specific gravity. That's the strength, something like that. So in the urine, for example, if I take just a half glass of water and put 1 scoop of glucose in it, then what happens? It is more concentrated. If I take full glass of water and then I put the same 1 scoop in it, then it is less concentrated, but it is having the same amount of the glucose. So the specific gravity is measuring what to what in relation to the solvent to the solute, how much amount of solute is present in that amount of solvent, that volume of the solvent. So here the high specific gravity, the higher concentration is present in oliguria because of less water, right? The half glass. Low specific gravity is occurring in polyuria because it's more water and the amount of solute is the same. Okay, fixed specific gravity 1.010 seen in end stage kidney disease where the kidney has no capacity of the dilution that is seen in chronic kidney disease, right? So high specific gravity, that is oliguria, less amount of urine is being passed and then more concentrated. Diabetes mellitus, that is glucose is a solute which is higher than the urine output. Nephrotic syndrome, protein is the solute, fever, dehydration. Low specific gravity, diabetes insipidus because of polyuria, low solute. Then chronic renal failure, compulsive water drinking. Okay, these are the examples. So for physical properties, you have to know the appearance, color, then volume, that is a quantity, then order, pH, and specific gravity. 6 things you have to remember in the physical examination. Now coming to the chemical examination, normal is 150, you all know. So the types of proteins found are albumin, hemoglobin, Bence-Jones proteins. So causes of proteinuria can be accidental, okay. Then physiological, seen in pregnancy, infancy, you do muscular exercise, then after cold, postural, orthostatic, then pathological, pre-renal causes. That means there is some pre-renal production happening, something like plasma cell myeloma, some tumors producing the proteins. So they are in excess, they have to be moved out. So that is pre-renal causes. Then renal causes, as you know, the filtration is not happening properly. There can be albuminuria that can be happening. So various renal causes we have seen while discussing about kidney disease, that is nephritis, too toxemia of pregnancy. Anything that disturbs the normal kidney architecture can intervene and release the proteins. Post-renal pilatus, cystitis, urethritis, prostatitis, any inflammation in the tract. So these are the causes of proteinuria. Then grading. See, we grade the proteins in terms of quantity. That can be mild proteinuria, moderate proteinuria, high proteinuria, heavy proteinuria when concentration is above 4 grams. Usually nephrotic syndrome, right? Moderate, that is 1 to 4 grams in 24-hour sample. If it is less than 3.5, we are talking about, we can list whole lot of nephrotic syndrome, whether it is streptococcal, post-streptococcal or post-infectious. It can be nephrotic if it is more than 3.5. per 24-hour sample. Mild when it is very, very bigger, that is less than 1 gram per 24-hour sample. That can be usually seen in something like minimal change disease or something. Usually it starts with mild, but then it becomes a heavy proteinuria, as you know, even in the minimal change disease, which is having good prognosis. So just remember that there can be grading of proteinuria, mild proteinuria, fever after muscle exercise, or some UTI. It is having mild proteinuria. So these are the examples: mild proteinuria, moderate proteinuria, heavy proteinuria, depending upon the amount of urine excreted per 24-hour urine sample. So what is microalbuminuria? Microalbuminuria is excretion of 150 to 350 milligrams per 24 hours. Okay. So it's the presence of albumin in the urine above the normal level, that is 20, more than 20 milligrams per liter, but below the detectable level of conventional methods. So that means your microalbuminuria is very, very difficult to catch. If we are able to catch microalbuminuria exactly, we can prevent lot of damage to the kidney by early diagnosis. So microalbuminuria detection is very, very, very important. Even every month a person goes for routine urine examination to check for sugar proteins. The proteins can be missed in the urine unless and until it becomes more like 1 gram or something. So this 150 to 350 milligrams, if we can find this, we can prevent a lot of progressing damage to the kidney. Okay, so how it is detected? Immunological strip test. I'm sorry that this has to be more than simple. Okay. It is an indicator of early and possible reversible damage to the glomerulus. So test to detect proteinuria. Qualitative test, heat coagulation test, simple random urine sample is sufficient. There is precipitation of proteins, both albumin and globulin by heat. See, for any practical examination, you have to write what test you are doing, what is the principle, then you have to write the procedure and your own result. Okay, this will be the protocol for anything, either urine or HB or anything. So I'll write the principle, then what is the procedure for heat coagulation? Take 3/4 of the test tube, then the upper part only you try to kind of put it on the heat. Then what you do is there will be cloudiness that will be appearing in the upper part, which is exposed to the heat. Why you are not doing anything with the lower part is that can be acted as a control. Okay, that is a standard that we compare with. So here we see that there will be some cloudiness due to the proteins which are present. So even the amorphous phosphates, I told you while talking about appearance, that can give haziness or cloudiness. So what do? You have to know whether it is a phosphate or a protein. So you add 3 to 4 drops of acetic acid. If it is a phosphate, it will dissolve. If it is a protein, it will not. So that is how you do a test for the heat coagulation to know about the proteins. So according to the turbidity present, you see this is no turbidity negative, visible turbidity traces up to 10 mg per 100 ml can be present, distinct turbidity that is 10 to 30, granular turbidity more than 30 to 200, flocculations more than 200 to 500, thick coagulum it is more than 500. Sensitivity of the test 5 to 10 milligrams per 100 ml has to be there. So microalbuminuria can be detected by this kind of a method. Okay, but usually this thing is not done now. Now that every lab is having that reagent strip test, they do that. Okay. So other tests to detect proteinuria, sulfur-salicylic acid test, equal amounts of urine, equal amounts of the reagent are taken, then the cloudiness or haziness you get, that is the sulfur-salicylic acid test. Contact or Heller's test, heuristics or albustics or stick test. Okay, that is almost like a strip. So these are the things which you have to remember by knowing about the proteinuria. So chemical examination, we started with proteins. In the proteins, we talked about why there is proteinuria, the grading of the proteinuria, the types of proteinuria. Then we spoke about the test, that is the heat coagulation test, which is the test for the proteinuria. Then we spoke about microalbuminuria. Then we are speaking about other tests that can be done, which can be other than the heat coagulation, like sulfosalicylic acid, contact heuristics, salvistics, and all of that. So there is a quantitative. We talked about the qualitative test. That quantitative test for albumin can be done for SPACs. Okay, that is sample of this test is 24-hour urine. This gives the reading in gram per liter of urine. I'm sorry. So that is it about the proteins. Blood in the urine. I told you for anything you have to know why it is there, the protein why it is there, blood why it is there, and what kind of test we are doing, what is the principle, what are the other tests. So this is the way, the procedure obviously. So this is normal urine. Does it contain blood? No. So it can be, whenever there is blood in urine, it is usually reddish or pink in color. Hematuria, intact RBC. Hemoglobinuria, presence of blood pigments, that is hemoglobin or myoglobin. So the chemical test is the one which you do, that is a peroxidase activity of the hemoglobin, which decomposes hydrogen peroxide and liberates the nascent oxygen, oxidizes benzene to give blue color. So how do you do this test? You take 2 ml of urine in test tube, which is previously boiled and cooled. Add 1 ml of clear benzene solution. Either, see, sometimes people will add solution, sometimes they add, they make the solution, that is the benzene solution, by taking acetylestic acid as adding the benzene powder. Usually the market is now supplying with the benzene solution only, because the benzene is the carcinogenic agent. Okay, so what do? Mix well, add this one to this, we add 1 ml of freshly prepared 3% hydrogen peroxide. So what do you get? If there is a green or blue color developing within 5 minutes, it indicates the presence of blood or hemoglobin or myoglobin in the urine. Very sensitive test for even small amounts of hemoglobin. So procedure, remember the hemoglobin has peroxidase activity. So this hydrogen peroxide which we are adding is liberating the nascent oxygen, and that oxygen which is liberated by the hydrogen peroxide is reacting with the benzene to give the blue color. So hemoglobin inherently has a peroxidase activity. The hydrogen peroxide is getting cleaved, liberates the oxygen. This oxygen then reacts with the benzene. So that is giving blue color. Okay, so this is about the benzene test. Alternate test, we have the orthotolerant Gregerson-Guekam test. So remember the alternate test, you have to remember the orthotolerant test, if at all they ask. So microscopic examination, urine is centrifuged. I told you centrifuge means you take a test tube, then you kind of churn it so many times, not churn exactly. The test tube is kept in a centrifuge and then you churn the instrument round, round and round. So then the sediment is examined for RBC under the microscope, and the number of RBC per hyper field are examined. Spectroscopic examination, look for typical absorption bands with the hand spectroscope. Reagent strip test is the most sensitive test. Presence of ascorbic acid, that is vitamin C. Everybody is taking vitamin C because of what? COVID. So ascorbic acid in the urine will interfere with this test. So hematuria versus hemoglobinuria, it can be pink, red, brown. Usually depending upon the severity, it can be smoky, acute glomerular nephritis, remember, so smoky. So color of plasma, normal, hemoglobinuria, it is pink. Chemical test, positive for both. In microscopic examination, you see the presence of intact RBC is hematuria, right? So you see red blood cells, but no red blood cells here. So that is about it. Then, as we saw about proteins, the blood, hematuria and hemoglobinuria, now sugar. Sugar is glycosuria. Less than 50 grams per deciliter is normal. More than 50 is abnormal. So qualitative Benedict test, you know, it is based on the property of reducing sugar to reduce a soluble blue copper sulfate solution into insoluble red cuprous oxide in alkaline solution. So there is this reducing property of a sugar in the urine that is reacting with the copper sulfate solution when and give the red cuprous oxide, and then it is happening when you impart an alkalinity to it. Okay, so how do you do it? 5 ml of Benedict's reagent, 8 drops of urine, drop by dropper. Then boil it for 3 to 5 minutes. Boil means just don't just keep like that. You know, sometimes it oozes out. Many students get burnt like that. So don't do that. Just 3 minutes. Then note the color of the precipitate after cooling. Benedict's reagent contains the copper sulfate, sodium carbonate, sodium or potassium citrate in distilled water. See, usually the examiner will ask what are the constituents of Benedict's reagent, and you have to say all of this. So interpretation, no change in color, negative, green, positive, yellow, orange, brick red. According to that, there are varying concentrations. Okay, sensitivity 50 to 80 milligrams per 100 ml. So more than 50, definitely you can detect the sugar in the urine. So Benedict's test is not just positive or giving color with sugars, but it is giving glucose, it is giving color with other substances which are reducing. Okay, so these reduction is happening by lactose, fructose, pentose and glycolipids. Non-sugar reducing substances are also there, that are uric acid, creatinine, homogenistic acid, salicylic acid, ascorbic acid, formalin, morphine, and anti-TB drugs. As such, ascorbic acid is being interfering with many substances, right? RBC there, I mean hematuria there, and then here it is the reduction of the copper sulfate solution with Benedict's reagent. So other tests, specific tests that are strip tests that are usually done for screening. How it is done? Because it is having a glucose oxidase that will get give a color. Ozone test, acidified urine is used along with phenyl hydrogen hydrochloride and sodium acetate. Then fermentation test, which is positive for glucose and fructose. Then there are other tests for reducing sugars. Just remember these names. Benedict's test is a standardized test. Okay. Other tests of glucose other than Benedict's, if they ask, then you have to say at least the names. Reagent, ozone, fermentation test, and all the other tests which are given here. Okay. Just remember the test, principle, constraints, procedure, advantages, disadvantages, you will be able to tell. At causes of glycosuria, why there is sugar in the urine, diabetes mellitus, non-diabetic glycosuria, there is no increase in the plasma sugar, but there is sugar presence in the urine. Why it is there? Because of renal glycosuria, alimentary glycosuria, endocrine disorders like acromegaly, hyperthyroidism, Cushing's, pheochromocytoma, damage to organs like liver, intracranial injury, renal tubular disease, and pancreatitis. That's the reason why whenever you are seeing, because there are varied conditions with glycosuria which are non-diabetic, you have to test for, whenever you are examining the patient, you have to test for the plasma sugar along with the urine sugar. So you correlate and then state that it is definitely a diabetic glycosuria. So this is about the urine examination. Just a recap of what I told. What is urine? How it is formed by the kidney. Then we saw that there should be some importance or indications why we are examining the urine. Then about the physical properties, appearance, color, order, pH, specific gravity, volume. Then we come to the chemical examination. We've finished about proteinuria, then blood in the urine, the hematuria and the hemoglobinuria and the sugars. So in the next class, we'll talk about the ketone bodies, bile salts, bile pigments, and also the urine microscopic examination that will be taken tomorrow. So thank you very much. You have to just go through your record once so that the record is having all the information. Just remember the standard test what you have to do in the examination, and remember the other tests also accordingly. Okay, thank you.